Hello friends, Dr. Ariel Blanco of Argentina has described a technique to avert the Argentinian flag in intumescent cataracts, and let's try to understand what he's saying. The pathophysiology is that in intumescent cataracts, the lens fibers get hydrated and swollen and partially liquefied. The newly formed equatorial lens fibers, however, remains intact and creates a ring leading to an anterior and posterior compartment on either side of the nucleus. When the anterior capsule is punctured, the oozing out of liquid cortex from the anterior compartment causes the pressure in the posterior compartment to become more than that in the anterior compartment. This leads to an upward movement of the nucleus, which causes the Argentinian flag tear. There is a pressure differential between the intracapsular compartment and the anterior chamber in these cases. To minimize this, one attempts a paracentesis and then hyperinflates the anterior chamber with high molecular weight viscoelastics. This only causes the intracapsular pressure to escalate further, putting the anterior capsule under a lot of stretch, which is why the capsule pops and an Argentinian flag tear occurs. Hence, Dr. Blanco suggests making the anterior capsule a puncture without even creating any sort of paracentesis. A 30-gauge needle is used to puncture the capsule, and to and fro movements are performed to rock the nucleus. One must, however, avoid side-to-side movement. The liquid cortex may also be aspirated with a syringe or just connecting the needle to an aspirating tubing of the Phaco machine. So let's take this particular intumescent cataract. I'm trying the Blanco technique. You need a special adapter, at least in the Stellaris machine, to connect the aspiration tubing to the 30-gauge needle. After fixating the eyeball and making the first paracentesis I perform is a 30-gauge needle, bevel facing down. And you can see that as it punctures the anterior capsule, the liquid cortex oozes out. Slight to and fro movements are made. This is to rock the nucleus. Please avoid making side-to-side movements, as this can cause the tear to extend. And then you can aspirate a little amount of this cortex. In a graded manner, the incision is then enlarged. The blue dye is then instilled into the anterior chamber. I created a small tear. This occurred while trying to take fixation through the corneal pocket incision. The air bubble is slightly rocked to spread the trypan blue solution evenly. The side port is then created. And finally, the main incision is completed in a graded fashion using a 2.8 mm keratome. The trypan blue is evacuated from the anterior chamber by using only viscoelastic. Don't use a jet of fluid, as this can sometimes get into the tear that you've made and cause the tear to extend. Do not overpressurize the anterior chamber, just fill it with enough viscoelastic and then attempt the capsulorhexis. I'm using a Utrata forceps. The initial plan was to create a small CCC to deturgis the lens further, but I got overconfident and therefore I tried to get a larger size CCC at one go. And this is probably the reason why the capsulorhexis ran to the periphery around the 1 o'clock position. If I'd attempted a smaller rhexis, I would have probably got away with a successful result. This of course does not speak anything against the Blanco procedure, which I think is extremely great. But once having done that, it's better to do a small size capsulorhexis and then deturgis the intumescence a little further before attempting the larger rhexis. So do a 2-stage capsulorhexis. Now I'm going to do the direct phaco job. I'm using the micropulse mode of phaco emulsification. The power settings is around 40%, and burying the phaco tip into the center of the nucleus with adequate amount of vacuum of 350 millimeters of mercury in this case, I'm able to create the multiple crack and separation of this relatively hard nucleus. Although there is a rhexis runoff at 1 o'clock position, by minimizing the stretch forces that is applied to the nucleus, I'm able to carry on with a reasonable amount of confidence that this tear is not going to extend to the periphery. So also, once you created the capsular rhexis, the cortex having oozed out, there is no further intumescence or no further stretch on the capsule at any point. Each of the nucleus fragment is then emulsified in the central safe zone. Careful rotation of the nucleus is done. There's not much of epinucleus, just a little amount of swollen white cortex. So in this case, I was able to successfully finish the Phaco emulsification in spite of a rhexis runoff at 1 o'clock position. I take abundant precaution in creating a viscofluid exchange before exiting the eye. The remaining loose cortex is then aspirated. This is quite easy. But you have to be careful while doing the subincisional area, as you don't want to hold on to any tags. The intraocular lens is then injected into the capsular bag, and you can more or less get the lens into the capsular bag. Therefore, the Blanco procedure, I think, really works, even though in this particular case, because I inadvertently tried to aim for a larger size rhexis, I had a rhexis run off. Try it. I think it may be the answer to intumescent cataracts. Thank you for your attention.